Hi, today we're here with Seema Mohapatra. Professor Mohapatra is a tenured faculty member at the Indiana University Robert H. McKinney School of Law. Prior to academia, she practiced healthcare law at two large law firms and earned her master's in public health and chronic disease epidemiology at Yale before earning her JD at Northwestern. She is the co-editor of Feminist Judgments, Health Law Rewritten with Lindsay Wiley, which will be published by Cambridge University Press next year. She's also a co-author of the only text on reproductive technologies in the law with Judith Darr, Glenn Cohen, and Sonia Suter. Professor Mohapatra's research has focused on equity issues in bioethics, public health law, and biotechnology in the law, particularly assisted reproduction, and she works to intentionally center race and gender to her legal analysis. Seema, we're so happy to have you here today. To start off with, could you generally discuss how race is a factor in the COVID-19 pandemic?
Sure. Thanks so much for inviting me to participate in this online symposium. And I'm so glad to be able to highlight the issues of race that this pandemic is bringing up. And I'm really disheartened by how often race isn't brought up when we have discussions of this pandemic. So I really appreciate this invitation to talk about this, because otherwise it's a huge blind spot. And the way that communities are affected by this pandemic, from being exposed to being tested to being treated to being stigmatized, it's all different depending on where they're coming from, and race and ethnicity plays a big part in this. So when states and communities are being asked to thinking about easing social distancing and getting, quote, back to normal, we really need to think about how different races and ethnicities will be affected and possibly harmed by that. One area that may need to be increased, that I would like to see increased attention on, is anti-Asian violence. And I want to focus mainly today on the inequitable impact that this pandemic is having on the health of African American, Latinx, and Native American communities, which is the subject of a paper I wrote recently with Rakaya Urabi at SLU, and it's currently under review, but it will be linked to the symposium video when we post it on SSRN. But I want to start with an issue that hasn't really gotten as much attention, and that is the othering of the Asian American community.
What do you mean by the othering of this community?
Well, although it's a sadly familiar story in pandemics, what I mean by othering is treating Asian Americans as if they don't belong in the community, even when they are third and fourth generation Americans. Starting as early as January 2020, when most of us weren't feeling the daily impact of this pandemic as we are now, in terms of the way our daily life is, Asian Americans were already starting to report discrimination, from microaggressions, like people avoiding them in grocery stores, to violent hate crimes. And this is all due to the mistaken belief that somehow Asian Americans are more infectious because the first known COVID-19 cases were in China. There's already more than 1,500 reports of anti-Asian violence or hate incidents since mid-March to now, and that's likely an underreporting. And in past pandemics, we've seen this occur as well. Often when there's an outbreak, reports of racism and xenophobia rise. We saw this in Ebola with people traveling from Africa or of African descent. We saw this when there was an outbreak of the hantavirus in the Southwest. Some journalists were calling it the Navajo disease, and there were reports of hate crimes or discrimination against Native Americans. And this othering of Asian Americans has been seen over and over again in our history, from the late 1800s to the early 1900s, from the bubonic plague and smallpox to the more recent H1N1 and SARS epidemic. But in the more recent past, like in SARS, we've actually seen the federal government respond more seriously to these incidents and have a plan for it, with the Justice Department Office of Civil Rights and the Centers for Disease Control better track and warn about these events, which is very unlike what we've seen during this pandemic. During SARS, President George W. Bush actually warned against anti-Asian incidents upon advice of the DOJ, but we've actually seen this administration fuel these racist fires instead. Although making some lip service to not discriminating against Asian Americans, the president has repeatedly gone out of his way to call this pandemic the Chinese virus or the foreign virus in tweets and in press conferences. And Asian Americans are reportedly calling into mental health lines at higher rates than pre-pandemic, which is really not surprising in light of the higher rates of stress in this pandemic, but also in the backdrop of increased stigma and othering. This puts communities at greater risk of anxiety and depression. And that's in addition to all the other health risks and collateral consequences of COVID-19.
Wow. So where can the law and policy play a greater role in terms of xenophobia and the anti-Asian sentiment that you discussed that's being seen in this pandemic?
Yeah, I mean, I think the federal government should do more of what they did during SARS, and especially the scale of this pandemic. We should be tracking this and playing a greater role in investigating these reports of violence and stigma. This is nothing new. In past pandemics or epidemics, the CDC has deployed a community outreach team at the same time, as the first cases of SARS, and that team actually documented and monitored acts of discrimination and work to support the affected communities and educate individuals and the general public against these unjustified fears. And we need something like that, both to prevent acts like this and also to help those in the Asian American community who may be fearful of such attacks, especially as there is a dialing down of restrictions and more back to business. Asian-owned businesses are likely to be affected by misinformation about this pandemic. So 16 years ago, the CDC published a report after the SARS outbreak that was titled Fear and Stigma, the Epidemic Within the SARS Outbreak. And in it, the CDC warned that we should deal with the fear a future epidemic will cause and focus on behavioral and health education strategies and providing timely attention to the special needs of affected populations. And we've kind of put that advice to the side. They're both needed now to reduce this kind of fear and stigma.
Well, thank you. Could you talk a little bit more about the health inequities that you mentioned earlier with other racial groups, and especially in terms of infection and death rates?
Yeah, definitely. In the last several weeks, we're seeing that even with limited data, we only have data from about 29 states as of today, we're seeing that African Americans, Native Americans, and Latinx populations are bearing the brunt of this pandemic. We're seeing this countrywide. The Washington Post reported that majority Black counties had infection rates 3 times the rate of majority white counties. And there was a CDC analysis of 1,500 hospitalizations in 14 states, and it found that Black people made up 33% of the hospitalizations, even though they only made up 18% of the population in those 14 states. And then when you look at the data more granularly, it's even more stark. In Chicago, African Americans account for 29% of the population, but have suffered 70% of the COVID-19 related deaths of those people whose ethnicity is known. And similarly, we're seeing this in other communities. We're seeing this with Latin American or Latinx populations in New York. Native Americans are being hard hit by this pandemic as well. In New Mexico, Native Americans are only 11% of the population, but account for nearly 37% of the COVID-19 infections and 26% of the deaths.
So the obvious question is, why are these rates so different in infection, hospitalization, and death for some of these minority populations?
Yeah, that's the key question. Minorities are being disproportionately affected with COVID-19, not due to any biological differences between the races, which doesn't exist, but it's because of a result of social factors. And it's primarily historical and current practices of discrimination. So the infectious nature of COVID-19 has emphasized how we're all interconnected, regardless of race, class, immigration status. But the ability to shelter at home and socially distance, to seek medical care, including testing and treatment, and to recover from COVID-19 vary considerably due to structural discrimination. And this is the very issue that Rakaya Urabi and I focus on in our paper.
So could you tell us a little bit more about structural discrimination, what it is, and how it relates to public health?
Yes, of course. So by structural discrimination, we mean the ways in which laws and policies are used to limit equal access to resources. So resources like safe housing, quality health care, high-wage jobs. Prior to the pandemic, racial and ethnic minorities, especially women of color, disproportionately suffered from poor health outcomes due to structural discrimination. And as a result of these inequities, they're more susceptible to contracting and dying from COVID-19 compared to white people. So if we're serious about addressing the problems that are arising from this pandemic, lawmakers must act to actually break down the root causes of structural discrimination. So that includes housing, healthcare, employment laws to protect minorities from harm and provide much needed support so we don't have the same situation in future pandemics or epidemics.
Could you discuss a little bit more about structural discrimination, let's say regarding housing, because I know you've written about this recently.
Yes. So structural discrimination in housing results in racial minorities more often living in substandard housing with greater environmental risks and food deserts. And those are all tied to greater risks or greater rates of cardiovascular disease and respiratory illness, which is kind of a perfect storm of sorts because these are also risk factors for doing worse once you're infected with COVID-19. And you're more likely to be infected with COVID-19 if you are living in a densely packed area, which the CDC says that people of color are more likely to live in densely packed areas and in multi-generational housing situation, which creates a higher risk of spread of contagious diseases like COVID-19. So if you're living in crowded living conditions in multi-generational families, in apartments where one is forced to interact with one another, say in an elevator or what have you, that makes it more difficult to avoid contracting or spreading the disease.
And you also mentioned structural discrimination in healthcare. What do you mean by that?
Yeah, that's an area that I've focused on a lot in a lot of my work. And there's really serious issues regarding structural discrimination that limit access to quality healthcare for racial and ethnic minorities at normal times, at pre-pandemic times. But it's even now more so during this pandemic. And things to think about are the closure of many health facilities in high minority populations like hospitals. Are we seeing that enough testing sites and hospitals for treatment of COVID-19 in areas that are easily accessible to minority or densely minority populations? And there's also known biases in healthcare delivery that may add to minorities delaying seeking care if they haven't had a good experience with the healthcare system in the past. And also structural discrimination prevents some racial minorities from even accessing any kind of healthcare services. So one example is undocumented immigrants, most of whom are racial and ethnic minorities in the US. They don't have access to purchase healthcare through exchanges in the Affordable Care Act. And due to the punitive immigration policies that we have in this administration, such as the public charge rule, and increased ICE enforcement that I know Wendy Parmet will cover in the symposium, undocumented immigrants are likely to avoid seeking care even when they exhibit symptoms of COVID-19. So that lack of access is directly responsible for poorer health outcomes and spread of the disease. And also, African Americans have long been subject to bias and poor treatment by healthcare providers. There's reports of many who are seeking testing who are being turned away and then have poor outcomes because their symptoms were not warranted to be serious enough to have testing. And when we consider the fact that African Americans, health complaints are often dismissed and not believed anyway in the healthcare system. There's a lot of studies that support this. There's reason to be concerned about African Americans' access to COVID-19 related care, even when they are able to see a healthcare provider. I could go on for a long time about this, but there's so much there. Dana Matthew has written about the structural issues in the healthcare system, such as explicit and implicit bias, which just compounds the problems in this pandemic. And there's a documented lack of African American, Native American, Latinx physicians in the US, and that also contributes to limited access to quality, culturally sensitive care.
I know you often focus on race and gender and how they contribute to healthcare inequities. Is there a gender component here as well?
Yes, there's definitely a lot of gender issues, and I think it's important in this case to think about the collateral health consequences of this pandemic, even in non-COVID patients. So it's well known that poverty is associated with child welfare involvement, and African American children are overrepresented in the foster care system. So there's a real concern that as people cannot work, lose jobs, get sick, or die due to COVID-19, their children may be taken away from them. And Kiara Bridges and Dorothy Roberts have done a lot of work in this area generally, and we should be thinking of this when we are going through this pandemic and thinking about other consequences that might not be as obvious. And additionally, due to shortages in PPE and the concern over infecting healthcare workers, some hospitals have limited how many visitors that a birthing person can have during delivery. And African Americans already face a 3 to 4 times the maternal mortality rate of white Americans. And in some cities, it's even greater than that. And that's regardless of income. And so one of the things that has been shown to be helpful with reducing that rate is birthing doulas, and that's been an effective way to mitigate this kind of harm. But due to visiting limitations, a birthing person might have to choose between having a partner or their doula or even any visitors at all. And these are all issues that are coming out that we should be thinking about that may have a disproportionate impact on African Americans. There's a whole host of reproductive justice issues that this pandemic is bringing up, and I know you have another panelist who's going to be covering those, but they really disproportionately affect poor women of color. And Liz Sepper and I are working on an essay about this, which I'm happy to link to whenever we're done with it.
Well, great. We'll look forward to that. So what can be done in both the short term and the long term about these issues?
Yeah, the inequities that we're seeing in this pandemic are predictable, and the federal government has really failed to plan properly to protect racial and ethnic minorities. And health researchers have long predicted that existing inequities would worsen in a pandemic. And so back in 2008, there were 2 studies that considered how to ensure racial equity in a future pandemic. And both of them suggested that we proactively address social vulnerability and exposure to pathogens, to susceptibility to disease once you're exposed to the consequences of the illness. And then think about how racial and ethnic minorities also, their disparities in housing and work and other conditions would make it difficult to follow mitigation efforts such as social distancing. We really should have heeded that advice. This is not a surprise. And these reports were 12 years ago in a prior smaller epidemic. And if we had followed those kinds of advice, we wouldn't be in the same position today. And so we should proactively follow that same advice so we're not having the same conversation again a decade from now. Short term, I think we really need more detailed race and ethnicity reporting related to hospitalizations and deaths from the virus and testing, and a better developed kind of action plan with what we're going to do once we get those rates and how we're going to attack that. The scholar Ruha Benjamin, she's noted that there's a lack of trust on the part of Black patients isn't really the problem with the healthcare system. It's the lack of trustworthiness by the healthcare system and medical industry. So we really need to engage minority groups and minority-led organizations about how to develop fair allocation practices for testing, for PPE, for workers that might not be getting PPE and might be exposed because they're essential workers, ventilators, clinical trial enrollment, future treatment, vaccine access. We need to make sure there's fairness in all of these kinds of aspects of the pandemic. And otherwise, African Americans and other minority populations are really bearing the brunt of COVID-19. So they really should have access to treatments and vaccines that will hopefully be developed. And we need to have race-aware policies developed in this regard. And so that can go a long way to being more trustworthy and to rebuilding trust and understanding in the healthcare system. And long term, we need to address the root causes of these problems: financial support, paid sick leave, comprehensive health care that's not tied to employment. We see the problems with that. With how many people are getting laid off or fired from their jobs. So that's just one of the many long-term but much needed solutions so that we're not talking about these same racial and ethnic inequities in the next pandemic or disaster.
Well, thank you so much for being with us here today. Your work is critical, and we really appreciate your discussing these very important issues.
Thanks so much for having me.